اتفضل يا حضرتك.
بسم الله الرحمن الرحيم. Diabetes clinical inertia. Type 2 diabetes is a major cause of death and morbidity. During 2021, according to the 10th IGF Atlas, there was 6.7 million deaths per year, a huge number of deaths. And in a study, the SHIV study, on 66,000 persons with diabetes, patients with type 2 diabetes had microvascular complications. 53% of these persons with diabetes had microvascular complications. 27% had renal disease. 26% had eye disease or eye problems, foot ulcers in 5% of the patients, and 39% had neuropathy. And the mean age of these people with diabetes was 53 years. Then this is a premature morbidity in type 2 diabetes. What is the global percentage of patients who fail to achieve the glycemic control? From a global type 2 diabetes study, 40 to 70% of type 2 diabetes fail to achieve diabetes control and hemoglobin A1C target. And there is additional risk factors. 85% of the patients are obese or overweight, and 71% have high blood pressure, 65% have high LDL cholesterol, and patients with type 2 diabetes are 2 times more prone to cardiovascular disease than those without diabetes. The goals in management of type 2 diabetes is to prevent complications and to optimize the quality of life. How to prevent complications? The first important method is glycemic management. Then cardiovascular risk factor management, weight management, and cardiorenal protection using the known drugs to prevent cardiorenal complications. The importance of glycemic control was shown in important diabetes studies like the UKPDS. Those who reached target hemoglobin A1C had lower macrovascular complications, lower cardiovascular complications, and lower cardiovascular mortality. And in the VADIT trial, also those reaching hemoglobin A1C target had lower cardiovascular complications. This is the advanced trial. In patients with macrovascular events, the percentage of those having macrovascular events in the patients reaching the target is lower in those reaching the target than those not reaching the target of 7% hemoglobin A1C. All-cause deaths also were reduced in patients reaching hemoglobin A1C of less than 7% compared to those who did not achieve the target hemoglobin A1C, and the microvascular events was lower in patients receiving target of 6.5 compared to those who did not achieve the target of 6.5 hemoglobin A1C. After 44 years of initiation of the UKPDS study, the legacy effect in those who had early intensive blood glucose control with insulin and sulfonylurea, deaths were reduced by 11%. Imagine this is in patients after 44 years of UKPDS trial started. 11% reduced deaths and 26% reduced diabetes complications in the form of kidney failure and vision loss. And early intensive blood glucose control with metformin led to 31% reduction in heart attacks and 25% reduction in deaths. This shows the importance of early and tight glycemic management. Let's now discuss the difference between sequential versus simultaneous approach in type 2 diabetes management. The clinical inertia exists in type 2 diabetes trial on more than 80,000 diabetic persons. It's a retrospective trial. And for patients on one oral antidiabetic medication, the patient to go to the second oral antidiabetic medication will take between 1.6 and 2.9 years. And to go for addition of third oral antidiabetic medication, this will take around 7 years. And to go for insulin, to add insulin, almost the patient spent 6 to 7 years to add insulin to oral medications. And to add GLP-1 receptor agonist or premixed insulin or bolus insulin, the patient will take more 3.7 years to be intensified. This is a clinical inertia. Delay in intensifying treatment, the delays are common, which is called treatment inertia, and the guidelines recommend that we only wait for 3 months to add another medication if the patient is not controlled. This is, again, the retrospective cohort study on 81,000 diabetic persons, and these are the causes of the treatment inertia: fear of hypoglycemia, fear of weight gain or weight gain, non-adherence to lifestyle modification, prescribed drug treatment itself, whether complicated regime or complications or side effects of the medication, and unwilling to use injectable therapy is among the causes of delayed treatment intensification or treatment inertia. Remaining uncontrolled due to failure to intensify therapy has significant implications on short and long-term complications of diabetes, while the impact of just 1% reduction of hemoglobin A1C in UKPGS for 10 years reduced the microvascular complications by 37%, the amputation or fatal peripheral vascular disease 43%, reduced deaths 21%, reduced heart attack 14%, and reduced stroke 12%. After another 10 years of the UKPGS, the risk of myocardial infarction and deaths from any cause of diabetes was observed to be reduced in those who had early tight glycemic control. This study showed patients who were delayed to intensify the treatment for 1 year, and the hemoglobin A1C stayed above 7%. And the study showed that after 5 years of delayed intensification for 1 year, there was increased myocardial infarction by 67%, stroke by 51%, heart failure by 64%, and composite cardiovascular events were increased by 62%. The clinical inertia definition is failure of healthcare provider to initiate or intensify therapy when indicated, and the main causes are lack of education, lack of training, and practice organization aimed to achieve the therapeutic goals. This is the updated 2023 ADA guidelines, and it is the same, no change from 2022. And the importance is the tight glycemic management using, and as beginning, metformin, then combination, and to consider avoidance of hypoglycemia as a priority in high-risk patients, And this is, again, the ADA 2023, the same algorithm, no change. And again, they stressed on the very high efficacy of certain medications, and among these medications are combination oral medications and combination injectable GLP-1 and basal insulin. This is the American Association of Clinical Endocrinology algorithm for management of type 2 diabetes. And we can find in those with severe hyperglycemia that we can use basal insulin plus branchial insulin or GLP-1 receptor agonist with basal insulin or GIP GLP-1 receptor agonist combination with basal insulin. And for those patients with hemoglobin A1C more than 7.5, we start with 2 agents of antidiabetic medications. And for those with hemoglobin A1C more than 9%, or those having 1.5% increased hemoglobin A1C than target hemoglobin A1C, we use 2 or 3 antidiabetic medications. Again, in the algorithm of the American Association of Clinical Endocrinology, in those patients with hemoglobin A1C above 10%, or if the blood glucose is above 300, with symptomatic hyperglycemia, we use basal insulin with GLP-1 receptor agonist. How to choose glucose-lowering medication? Providers should continually update their knowledge and know the efficacy and side effects of different pharmacotherapies. Identify the relevant comorbidities like obesity, cardiovascular disease, heart failure, CKD, or NAFLD, and assess the profile of the patient with diabetes. If younger age, then these patients need more tight glycemic control. If limited life expectancy in the presence of frailty, cognitive impairment, less tight or loose diabetes control in those patients, and to consider risk factors for medication adverse events, hypoglycemia in some medications like insulin and sulfonylurea, volume depletion in SGLT2 inhibitors, especially in older age, genital infections, concern with SGLT2 inhibitors, history of pancreatitis in all incretin-based therapies. And to send the patient for patient education sessions whenever necessary. Where is the place of insulin in type 2 diabetes? The use of GLP-1 receptor agonist should be considered prior to initiation of insulin. And when initiating insulin, it's preferred to start with basal insulin. When insulin is indicated, to continue organ protective glucose-lowering medications and metformin, because we usually forget to keep metformin beside the insulin regime, or also to add organ protective medications like SGLT2 inhibitors or GLP-1 receptor agonists. And to refer to patient education when initiating insulin. This is, again, AGA algorithm, and when we start injectable therapy, we can either use basal insulin, or to the left, we can find here, it's not very clear, we can find here to consider insulin together with GLP-1 receptor agonist. Thank you.
بنشكر الأستاذة الدكتورة إيناس شلتوت. في الحقيقة أنا هبدأ بس سؤال بسيط بالنسبة للجايد لاينز. احنا دايما في الحقيقة بيبقى عندنا choice. Still we have the choice نتيجة للكالتشر بتاع البيشنتس عندنا في مصر. What do you think about the patient-centered approach as a rule with guidelines?
يعني يمكن أنا جبت سيرته في وسط الكلام لما اتكلمت على اليونجر بيشنتس. اليونجر بيشنتس بدل ما عندهمش هايبوغلايسيميا أو هايبوغلايسيميا ان اويرنس، يبقى أنا بوصل لمور تايت جلايسيميك كنترول. بالنسبة للأولدر بيشنتس أو البيشنتس with cardiovascular complications أو kidney complication أو liver complication أو hypoglycemia ان اويرنس، يبقى أنا في الحالة دي بيبقى less tight glycemic control. بالنسبة للأولدر age ممكن أوصل لهيموجلوبين A1C target of 8% وساعات أكتر من 8% لو كان البيشنت عنده short life expectancy.
أي سؤال أو كومنت؟
إناس، بس أنا عايز أسأل حضرتك من خلال يعني خبرتك الكلينيكال انيرشيا، رأي حضرتك فيها مين أكتر، البيشنت ولا الدكتور؟
الاثنين
في مصر
يعني. الاثنين. اولا طبعا الدكتور يعني يمكن بيخاف من الاول ان هو يبقى مور اجريسيف. يعني احنا بنشوف حالات لغايه دلوقتي بيتقال لها دايت اند اكسرسايز وروحوا اصل ده سكر خفيف وكده، وطبعا الكلام ده مش مظبوط خالص. المفروض حتى لو كان البلاد جلوكوز في مرحله البري دايابيتس ان انا ابتدي ميديكيشن على طول. الحاجه الثانيه ان طبعا العيان ممكن يتاخر ما يجيش، ممكن ما يعملش تحاليل في وقتها وبالتالي ما يرجعش للدكتور. لما الدكتور يقول له تعالى بعد 3 شهور اعمل هيموجلوبين A1C ممكن ما يرجعش في نفس الوقت. التريتمنت انتسفيكيشن بالذات لما يكون في انجكتبل ثيرابي، ساعات العيان طبعا ما يسمعش كلام ويمشي فتره ويجي بعد سنه او سنتين بالكومبليكيشنز. فالحقيقه السبب فيها الاثنين، دكتور والبيشنت.
Thank you, Dr. Inass. Any question?
شكرا دكتورة إيناس.